So, good afternoon. My name is Maria Hodka. I'm a psychiatrist in the making and delighted to introduce Dr. Thomas Planck. Thomas headed the Austrian National EA chapter in the past. He has a master's in mathematics from the University of Vienna, a master's in psychological studies from the University of Glasgow. He earned his doctorate in clinical neuroscience from the Medical University of Vienna for neuroimaging research on the trajectory of depression. He has been training as a cognitive behavioral therapist and is currently working almost exclusively with patients from the EA community from all over the world. As a quick reminder, for questions, please use the Swapcard app. And now, effective psychotherapy.
Hi. There are different ways to have impact. Direct impact, more indirect impact, and perhaps indeed a more indirect way to have impact is to tend to the well-being and the functionality of the effective altruism community. And that indeed is precisely my job as a cognitive behavioral therapist working with the EA community. And this is precisely what I want to convey to you today. What does effective psychotherapy even mean, and how can you improve your outcomes? Part one, data. So as you can see from this illustration, which was finely crafted by Maria, especially for this talk, she feels data is a very stern subject, something that you need determination for. And what I'm going to present are results from the literature. They're aggregated meta-analysis, so not taking into account all the moderators, but just a brief overview of what the literature about psychotherapy tells us. But before we get into that, of course, I want to show you your survey results. Okay, need to get this over. Yes, here we go. Okay, precisely 100 responses, right? So you've probably engineered that, haven't you? And the first question I asked was, have you received psychotherapy or know people you care about that have received psychotherapy? This is really to show the relevance for the topic. And indeed, 82 people, right? It's difficult, easy to understand with the percentages. It's 100 responses. 82 people said, yeah, they have some kind of acquaintance with psychotherapy, either direct or via people they care about. And 18% say, no, that's not the case. Hopefully that's due to your excellent mental health. Please keep it that way. So the core question I was asking, and I'm seeing this data the first time as well as you do, was how helpful was the treatment to you? What did you experience? And apparently it looks like the bulk of people were around 7 or 8 points on the helpfulness scale, which is a good outcome, actually. But what the topic of this talk is about is really trying to shift the distribution to the right, trying to understand how you can improve your outcomes, perhaps particularly for the poor souls who have been well, at a 2 or 3 or 4 in this scale. So also an important factor is how much did you like your therapist? And apparently you have good allegiance scores, relationship scores. Maybe you're very agreeable people, I suppose, right? Making it easy for the therapist to connect with you. And this is important because therapy relationship is an important factor when it comes to therapy outcomes. Lastly, and this is a bit all over the place, but really estimating the length of the treatment. So many people have had a short treatment up to 10 sessions, but on the other hand, there's quite a number of people who had more than 20 treatments, which you'll see is actually a long duration when it comes to empirically supported treatments. Okay, now let me shift back here. Okay, so that was your own data, and what we want to look at now is the research literature on depression. And the first question we can ask ourselves clearly is, does psychotherapy help? Does it help at all? I mean, it's a particular health treatment. Does it work? And I put together some motley graphs that I painstakingly extracted from large meta-analytic tables. That is a study by Kuipers, 2014, about depression. And what you can see plotted on the y-axis is the proportion of patients who didn't meet criteria for depression after their treatment. So that is what we call remission, people being in remission. And interestingly, you can see here the proportion of people across a number of treatment modalities, right? All therapies, cognitive behavioral therapies, psychodynamic therapies. Now, psychodynamic therapies are therapies that stem from the psychoanalytic tradition, and some other like behavioral activation. Now, if your eyes go to that blue bar up there, behavior activation, please take into account the large arrow bars, right? So what you're seeing is not that one treatment is, superior to any kind of other treatment, but we know from the literature, and I'll make this stronger later on, that there are actually few or small treatment differences in effect when it comes to particular treatments. And there's also the waiting list condition. Now, waiting list does not only mean I'm waiting to become better and I'm just waiting for the psychotherapy to go on. Actually, registering your name on a waiting list has some benefits, right? There's actually benefits created just by you having a sort of perspective to get into psychotherapy. So that is not only spontaneous remission, these 17% in the mean, but we can clearly see that all therapies have an effect of up to, say, 60%. The second meta-analysis I want to show you is a study on the pre-post effect sizes for anxiety treatment. The effect sizes are given in Cohen's d. That's a measure, a standardized measure for the difference. And the effects you're seeing here are considered large. These are large effects. Again, CBT, other therapies, medication even this time, compared to a psychological placebo or a pill placebo. And you can see that in general the effect sizes for psychotherapy are quite okay, quite good. But of course, we're asking ourselves, what about the rest? Can we improve that in the effective altruist spirit? How can we make it more effective? Now, to get into this, you have to understand that psychotherapy research really looks at two factors: contextual factors and specific factors. Now, the contextual or non-specific factors, they pertain to all kinds of treatments. So these are factors that you will find in different treatment modalities, whether it's psychoanalytic or a humanistic-orientated psychotherapy. These are factors like empathy, positive regard, sort of soft factors that are sometimes difficult to measure. The specific ingredients or specific factors, on the other hand, are factors that pertain to the treatment itself. So say you're doing exposure therapy for your anxiety, that will be the specifics of this kind of training. And before I show you the graphs, I show you what you shouldn't care too much about, and hopefully this is surprising to you. At least it is to me. So you shouldn't care too much about the psychotherapy method, because as we've seen with the prior slides, with the meta-analysis, the effect sizes between the treatments are not all that dramatic, whether you're in CBT or a third wave treatment like ACT and commitment and so on. That doesn't matter all that much to your outcomes, and what you want to have are good outcomes, obviously. On the other hand, the therapist's gender doesn't matter so much. This is not a variable that, has a huge impact on your outcomes. And perhaps most surprisingly, experience doesn't matter that much, right? So if you're going to a psychotherapist and they have on their website 20 years of experience, that's not really the criteria, apparently, for outcomes, right? Whether somebody does it for 3 years working with patients or for 20 years doesn't make all that much difference to the outcomes. But what does? So this is from a study from a book from Wampold and Email in 2015. If you're interested in psychotherapy research, this is really the book to go. And they've tried to estimate the effect sizes of contextual and the specific factors. And if you look at the contextual factors here, what you really want to have in your treatment is a consensus on goal, right? So that is the most important factor that they found, a consensus on the goal. You're going to psychotherapy for a particular reason. It's not just that the psychotherapist is nice and you like to pay a lot. You want to go there for specific reasons, to work on your goals. And importantly, this factor is something that you can influence, right? This is something where you can say, I first like to deal with my relationship problems and then actually go back to, say, behavioral activation. And you have a dialogue with your psychotherapist about what the goals are and how to set them, because this will make you believe in the psychotherapy and actually be engaged. The next one is empathy. Now, empathy is something that you don't know beforehand. You can't read it off their website. Having 100% score 5 stars on empathy, that's not what you're getting, right? So in order to understand these contextual factors, you'd really have to have a first session with a therapist and see if they meet your needs for empathy, being able to say, I feel for you, this is difficult, can we try to improve that? Next factor is alliance, very closely related to these prior factors. You want your psychotherapist to be in the same boat with you. You want to have the feeling, this is somebody who cares for me, who cares for my progress, who cares for my improvement, well-being, and functionality. And these factors really have huge effect sizes when it comes to psychotherapeutic outcome as compared to the other factors. Now, turning to the rather atrophied specific factors on the right, these are treatment differences. So whether you're doing a sort of more confrontational therapy for your anxiety, say, or restructuring of your automatic thoughts, that would be the CBT tradition. It's not all that impressive, 0.2 effect size. And interestingly, this is rated competence, the bar next to it, and something that is more objective than just, the experience that I said you shouldn't care much about, but therapists rating other therapists for their competence, and it doesn't matter all that much, right? You could say that's a dire state of the field, and I agree to some degree. Now, but this is important to you because, you see, you want to be pragmatic when you're trying to find a therapist. And I know that in Germany, waiting times for therapists can be months if you apply for a therapy place with someone who is covered by the insurance. This will take months, and you're perhaps not too likely to get precisely the person you want, right, in terms of their profile on their website. But still, it might be a good idea to take that first offer and see if these other factors are fulfilled, if you can reach a goal consensus, if the person is empathetic, and so on. This is just another plot. Norcross and Lambert, just as Wempold, very renowned psychotherapy researchers, and I put in this chart of therapeutic outcome variance to highlight one specific point. Not the unexplained variance, that's the sorry state of our field, right? No, what I want to highlight is the patient contribution. Something you can do to achieve better outcomes, and I'll show you how in a minute. Now, talking about treatment duration, right? We've seen that in your own data, really a whole range, as I remember, from 1 or 2 sessions to 1.5 years and more. So that's really a broad bandwidth of durations. What you're seeing here is a survey of treatment duration for empirically supported treatments. So clearly, if you go to therapy, you want an empirically supported treatment, something that has a certain kind of evidence-based. For instance, if in Germany you're looking for a place, a psychotherapy spot that is covered with the insurance, these are empirically supported treatments. And what they did in that study is they looked at 58 supported treatments and asked, how long do they take? How long do evidence-supported treatments take? And what you see here is that most treatments don't take more than 20 sessions. Right, so some of you might have experience for a lot longer duration, and there might be reasons for that, of course, right? This is just aggregated data, and these are just empirically supported manuals, and they anticipate 20 sessions, but of course other problems might come up in the therapy, and life changes to the client, and duration might take longer. And if you're asking yourself, so how long should I wait? Should I wait 1.5 years until I see some improvement? No, you should wait around 10 sessions, right? Within 10 sessions, you should have the feeling that there is some form of improvement that you can point to. Some improvement, say, in emotion regulation, some insights into the mechanisms of your problems. And we know that on average, if you're in therapy, it's the 10th session. After the 10th session, your outcomes are declining, right? That means by every further session you're having, the outcomes, the return that you get from psychotherapy is reducing. Now, that doesn't mean, of course, that for some problems you need a longer time, or perhaps there are other moderators, like you need a while to trust your therapist and so on. And maybe these cumulative benefits over time stack up. There's no doubt about that. It's just that the rate of improvement typically slows down after the 10th session. Part 2, improving outcomes. Now that I've shown you some data about the psychotherapy literature and what the important factors are, what I really want to do here, and that's the part I care about, is I want to convey to you how you can approach psychotherapy to make it more effective to you, to use it for your own good, and hopefully for perhaps telling people you know and that you care about who are in psychotherapy. Now, the first question perhaps is, when should I even consider psychotherapy? When should I consider professional mental health care? And surprisingly, there are few good resources about this topic. As you can see from the drawing, ideally before your head is underwater, and we'll try to figure out what kind of warning signs there are for that. So first is a very clear one that you can't stop noticing probably. Your well-being is reduced. You're feeling down, helpless, hopeless, not being able to cope with the world anymore. and not just for the weekend, right? For a longer span of time. The International Classification of Diseases, which is the treatment, sort of the diagnostic system for psychiatric disorders, says in order to be diagnosed with depression, you would have this kind of low-key state for around 2 weeks. And as you might know, the main criteria for depression are low mood, obviously, anhedonia, which really means not being able to generate as much joy from the activities that you did enjoy previously, and fatigue. There are a couple of B criteria as well, so it's a heterogeneous disease, but one criteria for understanding that maybe it'd be a good idea to consider psychotherapy is reduced well-being over a longer stretch of time. Now, separated from this is functionality. Functionality is something different, right? It's on a, you can plot it on a different axis. Functionality really means my work, how am I doing in work, my social relationships, all the way down to simple household chores. And those of you who have experienced depression might find that at some point it becomes very tedious, very difficult to even carry out the easiest task that normally were routine for you. And that, of course, is a warning sign. If everything becomes overwhelming and really tough to manage and you're asking yourself, what is wrong with me? I could do this 2 months ago and now I'm struggling with these simple tasks. So that is another pointer to maybe you want to check with a mental health professional what's going on. Third, and I really want to stress this point, is a concerned social network. Now, this one is special. Why? Because your social network, these are people who know you over a longer stretch of time. They have sort of subjective, longitudinal data on you, right? So they can say things like, you were dancing around and being on the beach in the summer, and look at you in autumn, you're miserable, right? And that is a strong pointer because these people know you, they know you over a longer time, maybe your family, your friends, and if they say, well, something is wrong with you, you're different, you're not as joyful, we're worried about you, right? That's a key question. We are worried about you, about your mental health. Then, again, this is a sign to maybe think about consulting a mental health professional. Fourth is maladaptive coping. Now, that's a technical term for using dysfunctional strategies to deal with your mental health problems, right? There are many functional ways to try and deal with your mental health problems. Just take a walk, really, right? Taking a walk every day has some effect. But of course, there are also dysfunctional ways to deal with the anxiety that might have come up, the depressive feelings that are present at the moment. And for instance, a classical maladaptive coping is, of course, substance abuse, right? Drowning your sorrows in alcohol, classic. But this works in the short term, of course. It relieves the tension, it relieves the bad feelings, you're numbed, it's a bit better, but of course, over the long run, exacerbates things. Another maladaptive coping mechanism that we can see very often is social withdrawal. So you have a circle of friends, you have your families, and you feel overwhelmed. You feel down and sad and anxious, and the idea comes to mind, or rather intuitively, I should withdraw, I should hold myself back and close the door, I need time for myself, just be in my room watching YouTube, that's easy, that's nice, right, calm. But in fact, that's a maladaptive coping strategy because you're not getting the rewards, the feedback that social interactions, just as you're having them at this conference, provide, right? A third one, just as an example, is self-harm. So some people self-harm mostly in order to reduce the tension that they're feeling, right? Having a problem with emotion regulation, finding it difficult to to handle their emotions, they self-harm and thereby release the tension. Again, works in the short term perhaps, but in the long term, what you're doing is just hurting yourself, really. A fifth point is you're having high scores on self-screenings. Now, self-screenings are widely available, and I'll mention two. You'll find them on my website later on. For depression, there's a self-screening tool which is called, or a screening tool which is called the PHQ-9. And for anxiety, there's a tool called the G87. And with the help of these screening tools, you can assess, well, in a rough manner, your symptoms, say in depression or anxiety, if you think that is what's going on with you. And again, if you're having high scores on these self-screenings, then perhaps that's a good idea to think about contacting a mental health professional. Now, importantly, this is something I need to stress. There is no such thing as self-diagnosis. Please don't self-diagnose, right? That's what you got mental health professionals for. It's just not the screening tools. You can, if they are high scores, you can bring them to your mental health professional, say, these are the scores, look, it's drastic, and they will run with you through the diagnostic criteria and have a sort of a dialogue and testing about whether you really fulfill this or that psychiatric criterion. So this is really the core of the presentation, the core of what I want to convey to you today, something I designed specifically for this talk. I call it an EA-aligned client factor framework effect. And you'll see the points later, and they really spell effect. Took me a long time to engineer that, but I got it. Yeah, so you can remember, right? Effect, easy. It's an EA-aligned framework because it tries to orient itself by the literature. It tries to be as rational as it can, factoring in things like tracking outcome and so on, data-driven, and as rational as it can hopefully be. It's a client factor framework because this is really about you. Now, as I said, sometimes you might be able to choose your therapist, sometimes you might not. And sometimes the fit is not 100%, and you feel like, yeah, I can work with this person, but you know, it's not the greatest thing in the world. 80%, it's okay. But there's still something you can do to improve that. And remember the pie chart that I showed before with a 30% share of your contribution. And I want to show you how to get this up, not how to manipulate your therapist. The first one is ensure you're convinced of the procedure. You don't want to run a psychotherapy where you're not convinced, where you're saying, I don't know how this works, I don't know why I'm doing this. It's a strange procedure that I have to go through and I only halfway believe it. Indeed, you have to believe it, right? Because your expectations really have a strong role in the outcomes. So ensuring you're convinced about the procedure. And of course, there are different procedures available, right? There's cognitive behavioral therapy, for example, which is all about cognition, restructuring your thoughts, looking at core assumptions that you might have that might be dysfunctional about you, the world, or others. And also a behavioral component where you say, perhaps I can do things a little differently. Maybe I can run a behavioral experiment, come up on stage and talk in front of 200 people and whatnot, right? So really trying to get out and changing things. So that would be maybe the cognitive behavioral model. Of course, there are other therapy models too, like the more psychodynamic orientated models. So it really is about you. If you feel like my mental health has to do with thinking about childhood, with getting into my unconscious processes, looking at my defense mechanisms, okay, maybe that's more of a psychodynamic inclination that you're looking for then. Find goals and, importantly, remember to work on them. Now, you would be surprised how how often that isn't the case, where you're in therapy and you're doing something but not actually having goals, not knowing what to work on. And remember the large effect size, the first one, goal consensus. Indeed, the first thing you want to do is establish goals and actually stick to them. So oftentimes, and this is something that I've seen with patients in an out-clinic setting where patients came to me and said, I'm actually having psychotherapy. And I was saying, well, what's the problem? Why are you coming to me? And they were saying, well, you know, I just get into psychotherapy and I talk about how my week was, and that's nice, and then I go, but still the same problems. Yeah, well, that's exactly the case, right? You might feel well talking about your week and what came up and so on, but really what you want to do is go back to your goals and say, how do I get over my anxiety bit by bit, even if you have to deal with everyday things. Third factor, feedback. There's a sentence I like. I can't remember where I got it from. It goes something like this. The mental health professional, psychotherapist, is an expert when it comes to mental disorders. He or she is not an expert on your experience. You're the expert on your experience. So what you really need to provide is some form of feedback. And even the finer the detail, the better, even about the therapeutic relationship itself. Now, I know it can sometimes be intimidating to tell your therapist, I don't know if that procedure works, I haven't made that much progress, I don't feel comfortable perhaps in the way we talk. Would you be okay to receive more feedback? And these people are trained for that. They can deal with that. You see, the important factor in psychotherapy is that normally in everyday life, if you disclose difficult material, there's a probability that it will rupture your relationships, right? If you tell your spouse certain things will happen. Well, we can all imagine, right? But that is not the case in psychotherapy. These people are trained to get over the difficult material and talk with you about that without the relationship being ruptured. And that's a very strong psychotherapeutic factor. Fourth, engagement. So, of course, you want to be engaged in your psychotherapy, and that also refers back to the first point, believing in the procedure. Now, we know that oftentimes psychotherapies are not running well because people simply drop out and there's no more treatment. Right? So how would you improve without treatment? If you find yourself in a position where you miss appointments and schedule appointments in longer and longer time, coming too late to appointments, you actually might want to introspect on your engagement in the psychotherapy. This is a person that works for you, and you'd better be engaged. And if you aren't, well, you can talk to them. You can say, I don't feel engaged in this psychotherapy. I'm worried about the procedure, or you as a person, I don't think you're as empathetic as you could be. Okay, and the psychotherapeutic relationship won't rupture. It's not a standard relationship, a professional relationship, right? Psychotherapists can take that and be courageous to actually say that if it's the case. It's normal that engagement drops. It's not your fault. It's normal, right? That you say, oh, again, psychotherapy, right? I'm late, great, right? This is something you can talk about. Fifth, create homework tasks and do them. Now, with homework, not all schools of psychotherapy are equally likely to assign homework. But of course, think about it. You have 1 hour with your therapist a week normally, right? 1 hour a week. What about the rest of the time? The rest of the time is, rumination and feeling bad? No, you can do something about that. You can try and design homework together with your therapist that makes sense for you. Exposing yourself to new things, trying to write pro and cons list and reflecting on things, and you'd best to do that in concert with your psychotherapist's ideas. And of course, there's a second part of this, do them, right? You're in psychotherapy, you're spending resources and time on that, they're suggesting some homework, right? 20 minutes before the session, should I do it, shouldn't I do it, right? You better do it, because that's what helps. That's what's actually getting you more exposure to the things you want to work on rather than just this 1 hour of psychotherapy. Lastly, and I hope this seems very natural to you, track your outcomes. Now, incredibly, this is not standard. Think about the last time you went to a doctor. Say you had a cold or anything, right? Okay, you got antibiotics, and if that worked, you didn't go back to your doctor and that's the end of the story. If it didn't work, you came back and complained, right? So what kind of tracking measure is that, right? It's not really outcome tracking in any kind of a more scientific way. And you can do outcome tracking on your own, right? You know how to open a spreadsheet? Great, that's what you need to do. Write down the goals, ideally coming to some sort of operationalization, really how to put the outcomes into a format that you can track on your own. Now, I know this is not easy. This framework is not easy to implement because clearly when you come to your psychotherapist, you will be in some form of distress, right? You will be anxious or depressed, any kind of negative state, because that's why you're going to them in the first place. But I think even if you don't remember every point in the framework here, you can point to one or the other criteria that you can actually establish with your psychotherapist. And if you take a close look at the illustration here, again, finely crafted by Maria, the psychotherapist is startled about the effect model, right? So not every psychotherapist is used to that kind of thing, but again, you're effective altruists. Well, many of you sort of feel you're part of the effective altruism community. Even if you're not, of course, this framework works, right? You can try to implement one or the other point, say, at least tracking outcomes. Am I getting better? Now, and the next question to this, of course, is, and I got this question just before the talk, how do I know it works? Effect model problem solved, right? You have your outcomes. You can look at the trend. You can say, okay, I've been in therapy for, 10, 20 sessions, and it seems like the measures I'm interested in, I'm able to better cope with my anxiety. I've made a few new social contacts. Yeah, that is actually improving. I can see that in the trend. And this is how you know whether psychotherapy works for you or not. Maybe just a final thing, because that's a standard question. Should I switch therapist if I'm not satisfied? I'm in therapy and I don't know, maybe it could go better, not completely ideal. Should I switch psychotherapist? Now, this really depends on your pragmatic considerations. If it's very difficult for you to get another psychotherapist, say it takes months to get into another treatment because there are there's so much demand and so little supply that is covered by the insurance, say, you might actually want to improve your outcomes looking at the effect framework first. When you say, I'm having psychotherapy, yeah, it sort of goes along, I'm not making that much progress perhaps, try to introduce the effect framework. So I was on a talk and there are these points, can we do one of them, right? Can we do more homework? Can we do outcome tracking? And you might be able to actually improve the outcomes, the results, and the experience you're having just by introducing that framework without having to switch psychotherapists. Most psychotherapists are helpful, are thinking it's helpful if you're proposing something on your own and being engaged. So here I want to mention some resources. Slides, the references, the material and everything, screening tools. I'll provide them online, hopefully just shortly after the conference. But much more important than this, have a look at the EA Mental Health Navigator. That is a fantastic survey colleagues of mine put up, which is a service for trying to make psychotherapists available for the EA community. There are details on what they are doing. You can contact them, their contact details and everything. So please, by all means, consider going to that website, eamentalhealthnavigator.com. I'm having office hours at the conference. People from the conference were so nice to allow me to see you tomorrow 11:30 to 12:30 if you have any more detailed question that I can't answer right here. And if you have comments about the talk, anything you'd like to get off your chest, some research results that I should take into account and haven't, write to ea@therapy-blank.at. Before I get into the question, here is some final illustration by Maria. This happens. Okay. Okay, I'm just picking some questions here. Let me see. Oh, this one, for example, because this comes up often. I'm having the question here, what do you think of a client having both psychotherapy and life coaching together with the psychotherapy? So, at least in Austria, there's a legal framework for that, and it's supposed in many other countries too. So the point is that coaching is different from psychotherapy in the sense that coaching doesn't deal with clinical problems, with problems that lie in the clinical domain. So in theory, if you're in coaching and the coaching registers that there might be a mild depression brewing, then, well, the coach should actually refer to a psychotherapist who is more apt perhaps to deal with these clinical issues. But the question was, is it okay to be in both? Yes, perfectly, if you can afford it, right? Okay. Oh, that's another good one because there's literature on that. Do you think the 1 session per week model of therapy is ideal? Are there good superior alternatives? Now, you might have heard about psychoanalysis and their treatment modalities. And in fact, even before I started my education in psychology-related areas, I had the chance to be in psychoanalysis for 1 year at very amicable prices, and it was 4 times a week. So you're seeing your therapist 4 times a week. Now, this is somewhat unpractical, right? Because you have a job, you're working on well, with the A community, saving the world, and there's hopefully not so much time for psychotherapy. This is why homework is important. So in general, for most treatments, it's a kind of standard thing to have once a week, but for instance, we know from the literature that in depression, there might be a head start if you're struggling with depression, if you're having 2 sessions a week. So that is to some degree more effective than just having this 1 hour a week. Okay, that's a nice one. Are you worried about your public presence, like today? No, it scrolls away. Like today, ruining the blank slate required by the therapist-client relationship. Okay, now that you've all seen me here performing my talk, what would you think if you were actually in psychotherapy with me? This is actually an ongoing debate, and I know for a fact that there are psychotherapists for the community who do not engage in these kind of events anymore in order to avoid that kind of problematic overlap. But as I see it, I'm here in a professional role. I can have an impact, trying to communicate that effect model. And in my experience, this is perceived positively, and I didn't talk about all my dark secrets, so I think I'm fine. Okay. Okay, how do you explain the fact that some studies on CBT, which seems to have the strongest scientific foundation, is no more effective than other treatments? Exactly, right? You know, what psychotherapeutic research has done for decades is to pit one treatment against the other and trying to find out what's the best one, is it you know, modifying your thoughts, is it talking about your defense mechanisms and everything. But what I said here and what I try to bring across is that it seems like the specific modalities, for example, in CBT, behavioral activation, cognitive restructuring, don't seem to be so important. It's more like the healing experience you're having, and I know this sounds unscientific, but the healing experience, the healing rituals that you're engaging in to make yourself better seem to top the question of which precise treatment am I getting. And you might have heard of this nice name they have for this debate. The book by Wempel is called The Great Psychotherapy Debate, about roughly equal outcomes with all therapies. And this has the nice name, the dodo bird verdict. Right? It comes from Alice in Wonderland, where there's the dodo bird and they do their race, and all must have prizes. Right? It's the same with psychotherapy. They work, but apparently the specific factors are not as crucial as one might think. Okay, we can have one more. Let me see. Okay, there was one question about what is the harm of self-diagnosis? Why did I stress that fact, right? You're clever people, why am I sending you to these mental health professionals and so on? The point is that you'd really like to have the rating of someone else who is experienced with, say, depression, anxiety. And it's not easy for yourself to discern various kinds of very adjacent psychiatric disorders, say something like adjustment disorder, something like depression, or even the negative symptoms of schizophrenia. So if you self-diagnose, you might very well run into a sort of wrong conception of what's really been the case, the origin of your problem. So it is better to have a professional confirm your suspicion, and you might be right in many cases, and that's fantastic, perhaps with the aid of these self-screening tools. But you see, there might be one more component that you have missed, that you can't sort of introspect on very easily, which might put you into another arena when it comes to psychiatric disorders, which have a different way of treating them, and that might be more effective for your psychotherapy. And I think we'll close now. Thank you very much.